Hello everyone and welcome. Thank you for joining us for the NeHC University program today on ONC's National Health Information Exchange Strategy. This is Kate Berry, CEO of National eHealth Collaborative, or NeHC. NeHC is a public-private partnership with a mission to advance nationwide health information exchange to improve health and health care, including providing education on health IT. Today we've got a great program and a great speaker, Claudia Williams with ONC, and while she doesn't need it, I'll introduce her in a few moments. Next slide, please. NeHC offers a wide variety of education programs, including a Spotlight Learning Series on Health Information Exchange, Spotlight Learning Series on Consumer Engagement, Spotlight Learning Series on the Beacon Communities, Careers in Health IT, ONC Initiatives, and Trends in Health IT Innovation. Next slide, please. Our Spotlight Learning Series on Consumer Engagement in Health IT includes discussions of the opportunities and challenges of leveraging health IT to engage consumers, as well as case studies of consumer engagement best practices. Coming up tomorrow, May 3rd, we're hosting a webinar entitled Keeping EHRs Error-Free, the Value of Patient Engagement. So this program will cover a study that was done by NORC at the University of Chicago on the role of patient engagement to improve the quality of data in electronic health records. The presentation will include an overview of the issues of data quality of medical records, both paper and electronic, and the significant need to evaluate the role patients may be able to play to improve the quality of that data. On the slide here you can see the list of speakers for that program. Next slide. We're also continuing our series of in-depth case studies on the Beacon communities. So coming up on May 24th, we'll have a program highlighting case studies of the Utah and San Diego Beacon communities. Next slide, please. Since our topic today is ONC's National Health Information Exchange Strategy, I just wanted to take an opportunity to mention that just a few weeks ago, NeHC released a report entitled Health Information Exchange Roadmap, the Landscape and a Path Forward. This report summarizes the federal government's efforts to encourage and enable interoperable health information exchange. It provides several very diverse examples of market-based health information exchange that show that progress is being made and that there are many different approaches. And finally, it provides a process or a path forward for communities that want to make progress to implement health information exchange. We had over 75 industry leaders, including Claudia Williams, our speaker today, who provided input on the paper. So if you haven't done so already, please do download the report and let us know what you think. We definitely had a lot of feedback in the process that said that, you know, this paper it should be a jumping off point for deeper work on ongoing health information challenges. So we are launching a Health Information Exchange Learning Network. So we're interested in getting your input on what the most important issues to tackle as it relates to health information exchange are. So you can give us your input on the website. And I do think, by the way, there's a lot of really great alignment in this paper with the roadmap, as well as with ONC's HIE strategy, which Claudia is going to talk about today. You can download the slides from the program today at the URL on the screen. And next slide, please. Please do submit your questions as they come to mind. So we'll have a Q&A session after Claudia's presentation. And now I'm very excited to introduce Claudia Williams, who heads up the ONC's State Health Information Exchange Program. And prior to this, Claudia was with the Markle Foundation, where she headed up health policy and public affairs and helped to run the Markle Connecting for Health. Before that, Claudia directed the Synthesis Project for the Robert Wood Johnson Foundation, an initiative to inform key coverage, health market, public health, and care delivery policy decisions with strong research evidence. She's also held senior positions with the Lewin Group and the Office of the Assistant Secretary of Planning and Evaluation at HHS. Claudia has a master's in health policy from the Harvard School of Public Health and a bachelor's degree from Duke University. So now I'm very happy to turn the program over to Claudia.
Thank you so much, Kate, and it's delightful to be here today with And I'll also get to share with you some of the highlights from today's policy committee meeting that just a few minutes ago down the street. And next page, please. Oh, we have slow transitions here. You know, the rest of today's conversation is going to be about the progress we think we're on the verge of turning the corner on health information exchange due to a lot of hard work from many of you and also the building blocks that have been put in place through high tech. But I just wanted to take a moment to step back and see where exchange fits into the broader set of goals we all share to have Health IT lay the foundation for healthcare transformation across the nation. And I want to also take this chance to highlight the incredible progress we've seen in a very short amount of time. So today at the Health IT Policy Committee, CMS made its regular report on NeHC, and it reported that at the end of March, and actually those numbers are still coming in today, almost $5 billion in incentive payments have been paid out to providers. Not a single hospital has been rejected. All have succeeded in getting their payments. 76,000 providers have been paid, and we see a thriving marketplace of both full EHR products as well as modules that can be built. Many of the new vendors that are coming in are small companies adding jobs to our nation's economy. We also have seen that in this short amount of time, the RECs that have been established have enrolled over 40% of all the PCPs in the country, and that they're working with over 70% of the small practice providers in rural areas. So I just want to take a moment and congratulate. I know many of you have been the ones doing the hard work on the ground. This is hard work. This does not just happen. But I think we're really seeing incredible momentum and progress in laying this foundation for healthcare transformation that will extend, I think, very strongly into exchange over the course of this year. Next slide, please. So we've seen tremendous progress across the board in health IT adoption. And this year, with the foundation we've built in stage 1, with the increasingly rigorous requirements in stage 2, with standards adoption that drive down the cost of exchange, and payment reform providing a really strong business case, we expect exchange to take off in 2012. And our goal is to have information follow the patients wherever and whenever they seek care to support better care coordination. Exchange this year is one of 3 goals that Farza Mostashari talks about as the 3 goals for ONC this year, joining meaningful use and adoption and meaningful use acceleration, and also consumer engagement as the 3 main pillars of our work over the next year. Next page, please. So let's just take a moment and take stock of where we are. And some of these data are a bit old, so we're hoping a lot of progress has already been made because we're looking at 2010 data in some cases. But we know that in 3/4 of the time, and this is from a Commonwealth survey from a couple of years ago, PCPs don't get basic information from hospitals when those patients are discharged, 73% of the time, whether it's on paper or electronic. We know that for interfaces that exist, it often takes thousands of dollars to set them up, in large part due to the complexity of standards implementation, the fact that folks may not be doing it in the same way, but also in some cases because of existing business practices. So exchange volume is relatively low. The cost of exchange is often higher than we would like. But we're seeing tremendous growth in the field. We're seeing that 70% of hospitals, according to a CapSite survey, say they plan to invest in HIE services this year. And the number of active private HIEs tripled from 52 to 161 from 2009 to 2010. So I think we're in a world where, unfortunately, a lot of the information sharing that occurs is on paper still. A lot of it isn't getting to its desired destination quickly enough or accurately enough. But we're seeing a lot of hallmarks for increased motivation to participate coming, not just from our programs of meaningful use, but most importantly from health reform. We're also seeing that the marketplace itself is really evolving, where community level and even state level HIEs or HIOs are a big part of what's providing capacity, but we're also seeing EHR vendors, national networks, IDNs, in some cases quality organizations, play really important roles in enabling exchange in their own community. So we're seeing a very varied marketplace and quite different models also from place to place. Next slide, please. So just in terms of what we're looking for, this is the current state where only about 27% of the time discharge summaries get to the PCPs within 2 days, and where about 20% of hospitals or so were exchanging clinical records electronically in 2010, according to the AHA. Next page, please. And we're trying to really identify the motivators and building blocks that are going to create this kind of hockey stick curve that we've seen over time in e-prescribing. So let's spend a minute thinking about what created that curve in e-prescribing. Well, you do notice that in the early stages of 2007, 2008, we didn't see this sharp increase that we've seen most recently. But let's think about the pieces that went into this. We have changing professional expectations, where really it's the expectation, I think, for both patients and providers that there will be e-prescribing. Of course, we hope and expect that to increase over time with meaningful use. We see incentives as well as penalties for e-prescribing through both MIPA as well as meaningful use. And we see a standards-driven network that's really enabling cheap exchange to occur across the nation. So clearly what it's going to look like when we're dealing with health information exchange between a multitude of providers will be a little different than what we've seen on the SureScript network. But I think what we're looking to do is put in place the same building blocks of motivation, of standards, of incentives, and professional expectation that have really driven such a rapid increase in e-prescribing. So this is the curve that we're trying to create. This is what we're all after. Next page, please. So our goal, again, is that information securely follows patients whenever and wherever they seek care. That's an easy statement to make, and I think all of you know the hard work that it's going to take. We expect that there will be multiple ways of getting there, both suiting the particular task, what you're trying to do, whether you're trying to share a care summary or query a patient's information from an emergency department, but also depending on the business models and the way in which this gets constructed locally. So what we're looking to do at ONC is put in place the building blocks of both trust and standards that will enable multiple models of exchange to flourish and meet the needs of clinicians and patients to get their information, whether it's querying information again from an ED, whether it's sending a care summary when a patient is discharged, or whether it's me as a patient aggregating my own information so I can share it in turn. Next page, please. So we talked about the goal being information following the patients. We've talked about the fact that there'll be multiple models. We've talked about the current state of information exchange. But let's just take a minute to think about our approach. And I think really our thinking is really informed around a lot of work that's been done by Tim O'Reilly and others about what is the unique role of government in creating a platform for innovation and change. And it's not that we want to be the builder. We do not want to be the construction agent. We do not want to be the network and the owner. What we want to do is have the standards, the policy, and the services that we're enabling through our regulations and through our standards work be what's required from the private sector participants and from the public HIEs to put those building blocks together and enable cheap and valuable exchange to occur. So when you think about the Nationwide Health Information Network, and the words we use are very important, it's a set of standards, services, and policies that allow information to flow across the internet in a safe and secure way. And so it's not a single network, it's a set of standard services and policies that allow that to happen. We also, as I've already said, do not expect that there will be one solution or one architecture or one size fits all. We think these multiple approaches will exist side by side, but we want to enable all of them to thrive by putting in place the common building blocks that they'll need. So we'll be coming back to elements of this, this sort of trajectory and approach that we think about. In addition, we think of both exchange and interoperability as a journey, not a destination. We're not going to be done this year. We're not going to be done next year. But we're going to be continually evolving and thinking about the best ways to do things. So we may be focused today on how we can get ubiquitous directed exchange to make sure our care summary goes from here to there. But we're going to be moving quickly into a world where we need to be thinking about care coordination, care management across a care team that's distributed, and what kinds of platforms and exchange will enable that to occur. Next page, please. So we've talked about our approach, we've talked about our role, we've talked about our goal. Now let's think a little bit more tightly about the role that ONC plays. So it was really exciting to be at HIMSS this year and to see all of the work, really two themes driving a lot of the presentations, one being meaningful use, which of course is fabulous and wonderful, and the other being ACOs and health reform and medical homes and analytics and platforms. And it's clear that health reform as a driver has really arrived. Now that doesn't mean that every single hospital in the nation is going to be paid as an ACO this year. What it does mean is that everyone's seeing that it is coming. We are going to have the analytic and the quality and the HIT infrastructure to enable us to improve care, engage patients, provide care coordination. Beyond. So if we think of the business case for exchange, it is the business case that's provided by health reform, where no longer will provide paid on the basis of the transaction volume. They're going to be paid on the basis of the quality and the efficiency of the care they provide, and that cannot be achieved without health information. And efforts that have stalled in part because that business case wasn't really front and center, but it is today. Now, that business case is being provided kind of externally to ONC by the environment we're in, both through health reform that government is helping to drive, but also the private payers. But we have a really important role in driving down the cost of exchange, where I talked to a vendor recently, and they said, we want to make the transaction cost of moving a piece of information close to zero, so that we can spend our time and energy competing over value-added services to improve care for patients, but not on the nuts and bolts of how I get it from here to there. So really a lot of our efforts are saying, where can we drive down the cost of exchange with standards adoption, whether it's for lab or for transport or for care summary, as folks focus their innovation efforts on the higher end things that they're going to need to do for healthcare transformation. As information flows, as the value increases and the costs go down, information will flow, but it will only flow at the speed of trust. So we also have a critical contribution to the nation and helping align all of our various interests to create the conditions of trust. I'll be talking about that more a little bit later, that really allow adoption of exchange to take off. So this is the basic construct where we have a key role in reducing costs, increasing trust, and relying on the value that's frankly being created by all the important healthcare transformation work going on across the nation. Next page, please. So today I want to talk about 4 key goals we have for this year that build on the constructs I've talked about. First, more rigorous exchange requirements in stage 2. Second, the additional standards work we see and how we're building on the building blocks that are exist. Third, and I'll give you some exciting news about NWHIN governance and needing to put the requirements for ability. And fourth, the role that the State HIE program is playing in jump-starting services and policies. I'm hearing a little bit of static. I'm wondering if folks could mute their phones if they're not needing to talk right now, and that might help just a little bit. Okay, let's talk first about stage 2, and we'll move Thank you. Next page, please. Next page. Again, I'm sorry to interrupt. It does sound like there's an airplane taking off or something. So anyway, if you could mute your phones, that would be terrific. So one thing I just want to say before moving on, as you well know, the deadline for getting comments in on the meaningful use stage 2, both the standards and the CMS requirements, is the 7th. We would really appreciate all of your comments, both the things that you really don't like and think you should be taken out, and the things that you love and want to be sure they're in there. Please bring those questions, those comments on. We very much rely on the input from the public and from our policy and standards committee in shaping the final rules. But I think this was, of course, if any of you were there at the HIMSS event where we unveiled stage 2, I think one of the most important aspects of the Stage 2 requirements that are in the NPRM is the requirement that every provider participate in electronic exchange of information for care transitions. This is a hallmark next step for meaningful use. And what's exciting is how this can build on the important standards work that we've done, as well as, frankly, the expectations that are within medical homes and other kind of care transformation efforts that transitions are safe and secure to reduce unneeded services and improve care coordination. So as you know, the requirement as it stands in the NPRM is that 65% of transitions will be accompanied with sharing a care summary, and that 10% of those would be shared electronically across vendor and provider boundaries. There's also been a new requirement that blends several other ones that give patients an ability to either view their own information online or transmit it to a third party of their choice, like a PHR, where they might be able to access important models that we were talking about of sending information and consumers being able to aggregate their own. And finally, more rigorous requirements around public health and many other measures. So Stage 2, the NPRM really sets the stage for the kind of rapid progress and exchange that we need and want to see over the next couple of years. So let's talk now a little bit about the standards building blocks that are built into the Stage 2 requirements. Next page, please. Next page. So first, let's just take pause and remember the tremendous strides that were made to enable exchange in Stage 1, where we put in place the code sets and content and vocabulary that would enable every certified EHR to produce standardized content needed to do things like share a care summary, maintain a standardized med list, and consistently report quality measures. So Farzad likes to tell the story of when he was in New York, really launching TCIP, and he would ask vendors, how do you report smoking status? And they said, we can report it however you want. You know, you can record it this way or that way, or blood pressure. The idea that we have consistency in how things are recorded and the information that's provided and the code sets and standards that are used for that is a huge accomplishment. We've also heard a lot of feedback that those requirements could even be tightened and improved to allow for greater interoperability, but lots of important strides in Stage 1. Next page, please. We also see that for the first time ever in the NPRM, we have identified two important national transport standards, both direct and use of the set of standards from the NWHI and exchange code stack for sending messages that can enable exchange from any EHR system to another. And in addition, we have, for the first time, a national standard for a care summary document that was developed by clinicians in close partnership with standards folks that can enable the kind of rapid progress that we really want to see, what we talked about earlier about this incredible hockey stick that's possible. So while a lot of standard challenges remain, based on the work of ONC and its collaborators over the last couple of years, the initial building blocks required to kick off all three forms of exchange, whether it's query or directed exchange or aggregating my own information, are tested and available today, and this is a huge accomplishment. Next page, please. And this year we really are planning to address three missing components to support scalable exchange, and I'll be talking about some of these when we get to governance. First, the standards that will make directories queryable so that you can find and then send the information that you want. Second, the important trust layer around certificate management and discovery so that my EHR system can recognize the digital certificates of your EHR system. And finally, a comprehensive way to put in place the privacy and security and interoperability requirements that will enable rapid exchange progress and for trust to occur. So we'll talk about these in the context of governance, but we really see these as the next steps that move beyond what the EHR is able to do and the kind of code sets that are in that into the world where, as David Blumenthal used to say, exchange is a team sport, and what do we need to do to create that connective tissue? Next page, please. So let me just spend another minute on standards and talk a little bit about how we see these various building blocks being able to be stacked in different ways to support different kinds of exchange. So as you well know, we have different layers of the stack, from vocabulary to content to transport to services to policies, and they all need to work together to enable exchange. But we're also going to show you how these various pieces can be reassembled to accomplish different exchange tasks. So we have really put out a lot of important work through our S&I initiative, or Standards and Interoperability Initiative, in all 5 of these areas. Next page, please. So here we've specified some of the standards that are on each of these layers of the stack, both in Stage 1 and in Stage 2 meaningful use, and some of these also in the NWHIN set of standards. Next page, please. And what you can see is these get reassembled in different ways to accomplish different exchange tasks. So if you're sending a care summary for referral, you need the vocabulary and code sets that are going to the consolidated CBA. Then you can use either the direct or the NWHIN specifications to send the content, and then you use the provider directory to find the doctor, and certificate management and discovery to be sure you can create the end-to-end connection. So you can see how those pieces add up for a simple task that's in Stage 2 NTRM, like sending a care summary. Next page, please. But likewise, we can see the same set of standards being put together to accomplish the task of finding information when patients show up at an emergency room. But here you would need the additional layers of MPI, a data repository to query RLS, but you'd be relying on a lot of the same basic standard building blocks to accomplish the same task. So we've talked about Stage 2 meaningful uses for the exchange progress we want to make. We've talked about both the standards progress we've made as well as the next steps we need to take this year. And now I'd like to spend a minute or two talking about governance. Next page, please. So this morning in the policy committee, Farza made an important statement, and in the spirit of ONC giving no rest for the weary, this time it's not Christmas, it's not 4th of July, but we expect the governance work to be coming out soon after release of the final comments are due for Stage 2 meaningful use. So while we were accused of having a unicorn by the Standards Committee, and I know you've been waiting patiently for this, we will be releasing this very soon for comment, and we really would encourage you to take a close look at it and engage with it and give us your comments. Because there were so many questions on which we needed very open-ended input, we will be putting this out as an RFI that will be asking for input to a lot of questions and some structures that would then result in the release of an NPRM. It will be followed by an NPRM and then followed in turn by a final rule. But let me talk a little bit about the structure that you'll see when you take a look at that. So what we're putting in place is a voluntary program that would validate exchange organization. So it's a validation process that's voluntary. And what we've chosen to do is separate out that validation process from how you might leverage that validation process within a policy. So for instance, you might have a LEED certification for a building that is a government process. But or in that case it's not. But you might also have GSA deciding that it's only going to put its government employees in a LEED certified building. So we're focusing this effort on that certification part, the validation part of it. But there are lots of different ways both private and public entities could leverage this certification in their own efforts. What we've really heard is that in the absence of national guidance on interoperability expectations as well as privacy and security expectations, that there have been a lot of both state level as well as private sector efforts to put in place that kind of fabric of trust and interoperability that will enable EHRs and IDNs and national networks and HIOs all to move forward their work in a way that reduces cost and complexity of business agreements, but also in a way that allows information to flow securely across those different entities. And in fact, when we talk to states that have put in place their own kind of validation or certification process, they said, frankly, we don't want to be in this business. We'd much rather have national guidance in this area. So the objective is to really enable rapid progress and exchange, but also to put in place the conditions that allow a competitive marketplace to emerge for exchange, just as it has for EHR activities as well. So we would have criteria in there that have to do with the particular standards that might be expected around things like transport, querying, provider directories, the way in which certificates can be, both the policies for certificates as well as how they are discovered, but also the privacy and security expectations we might expect of these participants, and finally, what are the business practices that we would expect of every validated entity. So I won't be able to talk in a lot greater specificity today about this, but I really invite you to take a good look at this when it comes out shortly, and certainly to give us your input and answers to the questions that are posed there. Next page, please. Next page. So we've talked about the role that our standards work has in really lowering the cost of exchange, how we're using meaningful use stage 2 to set the bar and drive forward on the key next steps of exchange, especially around care coordination. We've talked about the role of governance in providing a fabric of trust and interoperability across the nation. Now let's talk about the State HIE program, where really our role is to jumpstart needed services and infrastructure to give providers viable options to meet meaningful use exchange requirements. And the focus we've placed is really mapping back to stage 1 and stage 2 meaningful use to focus on e-prescribing, care summary exchange, lab results exchange, patient engagement, and public health. The approach that states are taking is to make rapid progress, to build on existing assets and private sector investments, to recognize that every state is different, so there cannot be a cookie-cutter approach, and to leverage the full portfolio of national standards. So on the next page, we'll be talking a little bit about strategies. But it's really important to kind of grasp this approach, which is different from saying in every state there will be a single statewide network that will serve everybody's needs that's going to look like this. You'll see a wide variety of strategies and approaches depending on what's already in place in the state and what kinds of rapid progress might be possible in that particular area. Next page, please. So I want to just spend a minute talking about some of the most exciting strategies we're seeing at the state level and give you some examples. And I actually gave a much longer presentation on this at the February Health IT Policy Committee if you're interested. Let me just focus for a minute on white space and directed exchange. So what we're seeing in a lot of states, and Texas is a good example because I have that fabulous map showing a huge swath of white space basically from Lubbock on into the middle of the state, where there simply were not local exchange entities that existed in the state, in that area of the state. And really what they've done is try to put in place a market-based approach to jump-starting directed exchange. So they said, listen, we're going to put out a voucher system that allows any provider to basically purchase directed exchange capabilities that would allow them to exchange a care summary, share information with patients, and accomplish these different things. We're not going to own the infrastructure. We're not going to own the technology, but rather we're going to allow the marketplace that already exists for these services to serve these providers, but we're going to pay for it for a period to get things going. Meanwhile, Texas also took a hard look at other areas of the state where there were emerging HIEs and HIOs, and they said, okay, how do we support these local networks? Well, maybe we support these local networks by A, tying their performance to the important meaningful use requirements, funding them to extend services that support meaningful use, but also requiring them to follow a set of standards and privacy and security requirements that will eventually allow exchange across the different exchange networks. So then we're seeing in other states, and Texas will probably be there at some point, saying, oh my gosh, we have these existing exchange networks like in Indiana, but they've never been able to exchange across the state. So what's the kind of thin layer that we could put in place that would allow IHI finally to exchange with HealthBridge to exchange with the other networks that exist in Indiana? So we're seeing some very exciting work, whether in Indiana or Massachusetts or Tennessee, to basically put in place the infrastructure that means that even where you have robust exchange that exists, that it doesn't become an information silo only in one part of the state. So there's a lot of other exciting work going on in the HIE program, but I'll just leave you there for the minute. Last page, please. So we talked about the 4 key areas where we are driving progress this year, being stage 2 meaningful use, the making sure that Stage 2 standards support exchange, but also driving forward standards around some of the gaps, governance that will provide a fabric of trust, HIE program that's jumpstarting services, and what we're really hoping to accomplish is the hockey stick of exchange that we talked about earlier. But I want to just spend a minute talking about, as you tackle one, there was a fabulous phrase that Stephen Johnson uses in his book, Where Good Ideas Come From, where you can't really tackle the next problem until you're there, and he calls that the adjacent possible. So as our exchange activity increases, the adjacent possible also increases, as do the problems that we're going to face. So let me talk a few minutes about some of these things that I think we're really, my guess is many of you are already tackling in your organizations, but I think are really going to be the things we have to focus on now. So the first is that in a lot of structure has been put in place, and frankly also a lot of the initial deployments of direct, what we're asking providers to do is be in their EHR workflow, get out of their EHR workflow, go over to a portal, look at information, not necessarily easily be able to move that information into their EHR. And frankly, that kind of expectation that you're in one mode and then you get out of it, and that you're not being prompted and alerted and guided through that process, I think we've all found has really slowed adoption and slowed use of exchange. So I think we're really going to be faced with questions around how do you build that workflow into the providers, the workflow they're using to manage patient care. There are a lot of ways you can do that. One would be building those functions actually into the HR, but the other can be mapping, having good interfaces, but also mapping some of the workflow potentially from other platforms into the space that the providers are using. So that's a really important area, I think, for innovation and work over the next couple of years. Patient matching continues to be a really pain point, I think, for a lot of participants in exchange, and frankly raises a lot of patient safety issues, especially as we imagine exchange growing. The kinds of errors that could result from a bad match are serious ones, and ones that we have to seriously take a look at. So I think we're really interested, and I know many of you are, in thinking about the feasible, practical ways we can move forward in this. We know some people have been advocating for identifiers. Obviously, there's that issue was brought up and essentially rejected under HIPAA. We also think that in addition to those kinds of solutions that some people are proposing, there's a demographics are that you're looking at. How can we get the data quality on those demographics really good and clean? What are the algorithms we should be using for the match? What a lot of basic meat and potatoes work to be done in this area. Third, I think, and this is the problem that Indiana is lucky enough to have right now, how do we enable exchange infrastructure that can connect to the nodes of exchange so that we don't have a problem of walled gardens, whether that's in an ACO or, frankly, within a single HIO. I think there's a portion of this that has to do with interoperability and sort of common trust fabric, as we talked about for governance, as well as for Stage 2. But frankly, there's also a part that has to do with business practices, and we need to put in place the business expectations as well as the policy expectations that you can't just capture and hoard information. That information has to be able to follow the patient to where they seek care. Fourth, as information has hopefully will be moving from a trickle to a stream to a gush, we all experience every day the challenges of filtering information, whether on email or on Twitter or whatever other things we use. And I think there's a lot of exciting work going on right now, both in enabling much more, as some people say, Google-y type search, where you could enter a clinical term and basically pull up the information you want from various sources, but also find ways to help providers get the information just when they need it, but also judge the quality and accuracy of the information. We have a project going on with Regan Street that's actually proposing a kind of ranking system that says this information maybe should be looked at first and then second based on some algorithms that they're developing. Last are questions around liability, and these really span to the questions of, do I become liable if I don't look up a patient's information if it's available? Also, to what extent are different participants in information exchange liable for that information from a network level? And finally, what happens if I make a clinical decision based on information that might have been incomplete? So there are an emerging set of policy and legal questions that really need to be grappled with. I don't have a set of right answers right now, but we need to be dealing with those and thinking about those as we move ahead. So I'm sorry to talk so fast. I'm going to pause there. But first of all, I just want to thank all of you who are driving forward progress in this area. It's, I think it's hard work. It's critically important work. We rely on you to be sharing with us what the things are that are causing you pain and that you want help with. And you're really the ones driving progress and driving adoption out there in the field. So I just want to really thank you for your work. All right. I'll stop there and turn to Keith for questions.
Great, thank you, Claudia. That was a fantastic presentation, and we do have a lot of questions flowing. So I'm just going to jump right in. We have 15 or so minutes for Q&A. So first of all, Claudia, does ONC have a strategy for HIEs addressing confidentiality statutes protecting behavioral health population?
So. Let me parse that a little bit, and then I will also mention the people at ONC that are probably doing the most work in some areas, because it will certainly not always. So I think there's a great deal of interest allowing in creating pathways that allow behavioral health providers to participate in exchange. And some of that can be simply saying maybe the first step is receiving information from other providers. As you all know, to CFR Part 2, some information is protected in a different way and requires consent from patients before it's shared. So on a first order question, I think there's a lot of interest in figuring out, even if we're not ready to share behavioral health information with, let's say, with PCPs, certainly a great first step is having behavioral health get to have that information for the rest of the health system. Second, I think, whether we're talking about behavioral health or we're talking about other forms of exchange, I think we all recognize that we need to move to a more sophisticated way of dealing with consent and dealing with being able to share at a more granular level. And we have some exciting work, the standards and interoperability work in collaboration with Joy Pritz and her team to look at ways to manage that kind of more granular sharing, which frankly brings up a lot of clinical questions. It brings up a lot of how do patients process this information and make those decision questions. But it's an area where we see a lot of overlapping interest between the behavioral health community and, frankly, the rest of healthcare. In addition, we have an initiative with SAMHSA where SAMHSA basically funded several states to work collaboratively across their HIE entities, their Medicaid entities, and their behavioral health entities to come up with policy approaches that could work in those states, understanding that there are often state-specific laws in addition. So those are some ways in which we're moving forward on that important work.
Great. So Claudia, we have a question. I'm not sure if you'll be able to address this one, but related to the governance rule coming out. Do you know if that the envisioned governance model will cover both directed exchange as well as the nationwide health information exchange, and how might it relate to the current governing structures that may be in place?
Yeah, that is the kind of question that's probably best left to you perusing the document and asking your questions then. So I'll wait on that one and let you read the document.
Very good. So let's see. Oh, we have a question about, given that there are so many different models out there, will the lack of models or standards slow the adoption of health information exchange?
So what we're seeing is that, let's say I have a free-based approach to exchange and someone else in the state is having a direct-based approach. There are still going to be ways we can share information using national standards, but what we're going to start to need to have is a common way of thinking about trust and certificates and provider directories, and then ways to translate some of the approaches from one to the other. So an example is, within the direct standard, there's actually a translation piece that allows you to accept information from an NWHIN exchange participant. So I think we're going to start to see lots of interesting innovation around how you enable exchange across these different models. But frankly, what's exciting is something like the consolidated CDA, which is basically a really great care summary document, can be used regardless of the model and regardless of the approach. So I think I don't see any dead ends here, but we're going to need to be innovative and creative about how we move forward.
So we have a comment about meaningful use stage 2 and the comments about reducing or actually lengthening the time it takes for the patients to get their discharge summaries. I guess there's a change from 30 days or something. So can you comment on what ONC's position is on that?
You know, what's great about rules is they're the full meal from appetizer to dessert. So they provide in the preamble the justification for the different approaches and also the rules themselves. So I'd invite whoever has thoughts on that to look at the rule, and then if you have like to share with us, please submit those comments. We're very eager to hear them.
We have another one sort of related to isn't the goal, I guess the comment is, isn't the goal to have a single national data exchange any community-driven HIEs?
No, we don't see that as the goal. We don't actually, we think just like the internet, that a lot of people are going to be using the same standards and protocols to participate in exchange. But that doesn't mean we have a single architecture and a single model. So what we really use the internet as the model to think about it, where you're trying to standardize the core basic protocols, but the business entities will be very divergent from public entities to private vendors to maybe single IDNs. And we try to be careful to distinguish the conversation about what are the standards and what are the trust requirements from what are the kinds of business approaches you could take to enabling exchange, where we frankly think it's going to be a great variety. Some will be more successful than others depending on the geography, motivation of the people participating, etc.
Claudia, there was a question about, is the provider data in the provider directory going to be available to the public?
Well, actually, it's interesting. Right now, through querying your state medical licensing board, people can get a lot of information about providers in their communities and states. But we do envision, with more robust provider directories, probably having a lot more information. And there is some concern from providers about provider identity theft and wanting to be sure that those more robust sources of information are protected to those who need it for electronic exchange, which could include the patients in some circumstances. So I think I think we're still kind of evolving the direction that's being taken in things like provider directories. But I think it's going to be important to balance providing flexible directories that can be queried, making sure that appropriate privacy and security provisions are in place so we don't see identity fraud from providers, and also giving patients the information they need about providers to make important decisions.
This is kind of a detailed one, so bear with me. We have scenarios where we want to exchange CCDs that are not health summaries. Would that still meet meaningful use criteria? For instance, we request mammography from outside providers, then we receive the mammography results as a C62, not a C32. Does that meet meaningful use criteria, or does it have to be a C32?
So under stage 1, you would have to follow the standards required information, but let's remember under stage 1, the care summary exchange piece doesn't actually require electronic exchange. It can be accomplished on paper. As we're moving to stage 2, and now remember these are proposed rules, they're not final, the standard has been shifted to the consolidated CDA, which is a more constrained version of the CDA that was developed with a bunch of input from vendors and from providers and from others. And a portion of those would have to be accomplished electronically. So I would encourage the person questioning, if they're trying to achieve meaningful use, they would have to follow the standards in stage 1. As we move to stage 2, assuming that the consolidated CDA stays in there, we would be moving to that standard for the care summary.
So we have a sort of a question and a comment. Do you know how many doctors have met stage 1 meaningful use so far?
Well, let me answer that. Let me just look here. So the latest numbers that were shared by CMS today are that 44,000 doctors, professionals, have been paid by Medicare, and about 30,000 have been paid by Medicaid. I think all of those Medicaid numbers are AIU. So if you remember, for Medicaid, the first year you can get paid by having a certified system. We've had roughly 74,000 providers paid. About 44,000 of those got paid under Medicare, meaning they had to attest to the meaningful use requirements, and the rest were Medicaid.
And the follow-up comment from this person was sort of, physician adoption of the technology may be lagging a bit, and that ONC is kind of far ahead of the community, which I think is a good thing in the sense that the programs are encouraging. But did you want to have any comment back to that?
Well, I don't know. I think 40% of the nation's PCPs signed up with RECs is a leading indicator of a lot of engagement. For sure, any kind of health, IT transformation like this, there are going to be certain folks who don't participate, but we're feeling incredibly encouraged both by the meaningful users, but also by the REC participants, but also the vast majority of rural providers participating. So I guess I would just say from our standpoint, these numbers are truly astounding.
It is a lot of progress, very fast, as you said earlier. So another comment around the patient. How is ONC thinking about handling, reliably patient identification to allow patients to securely view, download, and transmit their own health information?
Yeah, that's actually an interesting issue that was discussed today by the policy committee. As you know, there's a work group of our policy committee that devotes itself to privacy and security, and they were recommending single-factor logons for patients, recognizing that I think we'd all like to move to even more secure requirements, but we're going to have to put in place a lot of infrastructure for that. So their recommendations today were that we at privacy and security, certainly the security of the systems themselves and encrypting information at rest and in transit is critically important. They did recommend single-factor authentication for patients.
And so a lot of people come from other countries for healthcare here. How can their information be made available through these standards and health information exchanges? And furthermore, if people come to New York and then are later transferred or cared for in Texas, how does their information get transmitted, and how would an international patient access his or her health records to download? It's a big one. It's a tough question.
Give a little anecdote that I think is pretty exciting. So we have the island of Guam is one of our grantees, and they have just been going gangbusters. Now, admittedly, they have a fairly small provider base there, but they've been really aggressively deploying direct as a way to enable care coordination among providers. But the vast majority of their hospital care is provided in the Philippines and other places. And they've actually been talking about giving patients access to patient-facing tools like a PHR, where that same protocol direct could potentially be used to put a care summary in their PHR that would then be available to them whether they're getting care in Guam or whether they're getting care in the Philippines. So, obviously one pathway is to have data use agreements between the Philippines and Guam and have those folks figure out the way they're going to do it. But we think that's a really great scenario for thinking about patients playing a role, especially for planned care, in transmitting their information across state boundaries and national boundaries.
Claudia, is it planned that transmission of structured data, such as dictated or transcribed reports, would be accepted into EHRs?
I'm not sure I know the answer to that. I'd rather take a pass just because I know little bits of information, but I'm not sure I'd give a full answer.
Okay. If there's just sort of a comment on that, if it is not a one-size-fits-all approach for HIE, why require direct to HIOs that are beyond the basics of direct?
You know, I think there are different, let's parse that question a little bit. There are different kinds of use cases and tasks. So one use case is that I'm sending a care summary to someone for planned care when I'm referring them, and that requires me to be able to push a message to you and have it confirm that it arrived. Another important use case is that I show up at the ED, I didn't expect to get care, and you need to query my information from a repository. So we think that different standards play really important roles in enabling different forms of exchange, but we do think that while some of the query infrastructure takes a little bit longer to put in place because you need policies for who's going to be able to access the information when it's remotely in a repository, we've seen in some areas directed exchange quicker to get going because it can rely on the existing fabric and HIPAA requirements. But we think that both forms are critical and essential. We want that, and in fact, even direct can play a really important role in enabling query. What we're seeing in Rhode Island, for instance, is that they were finding that their EHR was really hard to populate the repositories so that the repositories include not just hospital information, but also ambulatory information. And I think many of you familiar with query-based exchange know that a lot of those models mainly just have hospital information. So essentially what they're using is they're triggering a care summary from the EHR to be sent by direct to the repository so that that repository has a much fuller complement of information than what it had before. So we can think of direct as just a standardized way to do a push that might be reused. It's not a business model. It's not an information exchange approach. It could be used for a lot of different use cases, both to enable query and to enable a push message to go.
So we have a lot more questions, but we're probably going to have to just go with one more given the time. So Claudia, can you talk a little bit about ONC's strategy for patient engagement and the role that the state HIEs might play in providing personal health records or provider-directed exchange with patients? You know, and I guess I'll leave it at that.
Sure. Well, actually, we're really excited about this area of work. We had a challenge grant initiative that we funded last year in January, and 2 of our grantees were specifically working to allow HIE data to flow into the hands of patients. So in Indiana, we have really exciting work in collaboration with No More Clipboards to allow all 5 of those HIEs to pilot patient access to information. None of those HIEs have been doing that to that date. And in Rome, Georgia, we have a really exciting model. They actually don't have community HIE activity there. Using directed exchange more for both the providers to share information, but also to share information focusing on cancer care coordination. About 2 months ago, we also invited other state folks to come to the table with their project ideas, not in this case with funding, but with a lot of encouragement, a lot of support from us, I guess. And we met in Chicago with, Corey, how many? 6 states. It was very fascinating that our 2 existing states, Georgia and Indiana, both came forward with new ideas. For instance, Indiana wants to share immunization records with families. But also we have Nebraska, which is a really wonderful, robust exchange, partnering with employer groups and others and payers, again, to allow information to flow to patient-facing tools. So this is an area that requires some real thinking on the part of HIEs who maybe are still trying to figure out how it fits into the business planning and how do you deal with patient ID proofing and things like that. But we see a great deal of excitement and interest, particularly in partnership with payers and also particularly to support health reform activities.
Wonderful, Claudia. Thank you so much. This was really a great program. I think we're going to have to do a part 2 because we have a lot of our audience's questions that we weren't able to get to. So maybe you'll join us again and we can do more of an open Q&A conversation. So Claudia, thank you so much, and thank you everyone for joining us today. When you log out, a quick survey will pop up on your screen, and so please take a moment and complete that. We do really appreciate your feedback, and many of you will join us tomorrow for the program Keeping EHR's Error